Okay, first up, we have 4 oral presentations. Dr. Ramyar Abdullah is first.
Thank you. Hello, everyone. It's Ramyar Abdullah. I'm the intern at Augusta Internal Medicine Residency, and here with me is Dr. Sheikh. He is the PGY2. Our study is about early versus late initiation of G-CSF in patients who have absolute neutrophil count less than 500 at Augusta Health. Uh, I'll hand it over to Dr. Sheikh. He will do the introduction and the methods of the study, and later I'll tell you about the study results.
Good morning, everyone. Thank you for being here. So, Dr. Abdullah mentioned we're talking about early and late initiation of G-CSF in patients with neutropenia less than 500 neutrophil counts. So this is a retrospective cohort study done at Augusta Health. What we tried to achieve was the question that we asked was, does initiating G-CSF within 24 hours of admission versus after 24 hours reduce the length of stay or 30-day readmission, um, all-cause readmission? Um, Diving into the clinical problem a little bit. So severe neutropenia is ANC less than 500, which is a high risk state that requires hospitalization. Febrile neutropenia is defined as one of the most common causes of unplanned oncology admissions. Prolonged hospitalization increases the risk of infection and healthcare costs. And GCSF care currently is the standard guideline care, supportive care. It reduces febrile neutropenia incidence and the duration. The gap that we wanted to address for our study was that current guidelines do not specify when GCSF should be initiated after hospital admission. And that was the question that we asked, and we wanted to study the impact of that. Um, so, this was a single center retrospective cohort study done at a community hospital from December 2018 to December 2025. The population that was recruited were adult inpatients over the age of 18 who received at least one confirmed GCSF dose. And the unit of analysis for us was individual encounters. So if they had multiple encounters, they were counted separately. These are various GCSF agents that are difficult to pronounce, but they are all filgastrum, and they all are biochemically the same, but they're used in different scenarios in an oncology setting. And our outcomes, the one that we primarily looked at, were index length of stay in 30, and then 30-day all-cause readmission. Secondary outcomes that we looked at were discharge ANC count. So what was the ANC count at the time of their discharge, and depending on how many doses of filgastrum they got. There were a total of 235 encounters, out of which 123 encounters were counted as early initiation, or they received GCSF at less than 24-hour mark, and 112 out of those who were received after the first 24 hours. For the purposes of our study, we looked at our primary cohort was about 100 patients, and the reason for that was because those 100 patients basically they had ANC of less than 500 on admission. So that was our primary cohort. Demographics, I'm going to go into it briefly. About 63% of the patients were 65 and above, 57% of the patients were males, 10% required ICU admissions, and 89% did not require ICU admissions. Number of doses, about 66% of the patients got two or more doses, and 30-day readmission rate was about 11%. Um, So this is where we this is where we differentiated the timing. So early group got G-CSF at 18.5 hours. This was the median time. And the late group got G-CSF at about 52.3 hours. This was the most common time that they received fulgastrum or G-CSF. I'll hand it over to Dr. Abdullah to discuss the results.
Thank you, Dr. Sheikh. So, regarding the timing, just to give you a context, when we say like early initiation, it's like the timing between the patient having orders that they are getting admitted till their first dose of the GCSF. And with the calculated ANC was from the first CBC that they got when they got into the hospital. And the first three sets of temperature would like define if they were febrile or not. So between the primary cohort where the people who had ANC less than 500, which is a definition of severe neutropenia, and for some reason the decision was made that they would get the GCSF. And our question was, if the decision was made that the patient will get the GCSF, would it make a difference if they get it less than 24 hours, or it won't make a difference and regarding the length of stay and also the 30-day readmission rate. So the primary outcome about hospital length of stay, we found out the early group, which was like 81 patient who got the GCSF less than 24 hours. Their median day of stay was 4 days, and the interquartile range was around 3 to 5 days. But the late group, about 19 patients, their median days of stay at the hospital was around 7 days. And there was a difference of 3 days. So in the group who had GCSF less than 24 hours, their length of stay was 3 days less than the group who had late administration of GCSF. So, and the p-value was significant for that. The other outcome where we looked at if, for example, you discharge a patient earlier than the other group, there's always this question, was the discharge premature and are they prone to get readmitted? So we looked at the 30-day readmission for any cause, and the early group was like around 17.3 and the late group was around 15.8. But the difference wasn't significant statistically because the p-value was around 1. So we came to the conclusion that people who get the GCSF and their ANC is less than 500 earlier have usually decreased length of stay. And we also had a subgroup analysis. So the main cohort was the people with ANC less than 500. And we also looked at the people who were outside of the ICU, medical floor, PCU. And the difference was also significant at that group. We looked at the people who were admitted to ICU admission. Because the sample size was smaller than the other subgroups, the difference was non-significant statistically because there was only 5 people who in the late group arm. Then we also subdivided the people with ANC less than 500 who had fever, all had like a confirmed infection. And there was also 4-day average when they got it early. And when they got it late, it was around 8 days length of stay with a difference of 4 days. And that goes along for febrile neutropenia as well. People who had ANC less than 500 and they had a confirmed fever of 38 or more. So just coming to the clinical implications and conclusions of our study. So the key conclusion was in adult inpatients with ANC less than 500, if you administer the GCSF less than 24 hours, it would reduce the length of stay by around 3 days without increasing the 30-day readmission rate. And the benefit was consistent in the subgroups of non-ICU, febrile, or any confirmed infection or sepsis. And the thing that we want to work on is like we are trying to do a QI project in the next year to kind of implement the administration of G-CSF into the modules when you admit a patient who had ANC less than 500. The decision to give ANC to a patient with ANC less than 500 is kind of nuanced, and you have to take into account their risk factor of being like getting a severe infection. So our study didn't like address if which patient population should you give it. It was just about if the decision was made to give this patient a G-CSF, would it make a difference if you give it earlier or later? And it does without like increasing the 30 days readmission rate. Thank you. Any questions? I promise it was an AI mate. I'm kidding.